Thank you, Roxana, and it's really a privilege to be here. It's my opportunity to kind of make the circuit in New York City now that I'm a new resident of New York City, and it's fun to see my really good friend, Dr. Fuster, Dr. Bott, Dipti, et cetera. So it's really been a privilege to be here. My disclosures. Now, Roxana has given me a daunting task. Number one, she's asked me to follow Dr. Fuster, which is something that you usually don't want to do. The second thing she asked me to do is she said, okay, there's been 100 years of progress with the AHA. What's next? And by the way, you have 15 minutes to do it in. So I will try to do my best here. And so what I'm going to try to focus on is big themes. Dr. Fuster has given you a lot of the underpinnings of the science. And I think the message that as Roxana and Dr. Sharma said, you're going from intervention to prevention. I hope that by the end of Dr. Fuster's presentation and by the end of my presentation, that you're going to all think that we need to be preventive cardiologists. And I'm going to try to share with you some of that data. As Roxana said, I was just in Chicago with some of you for the celebration of the 100-year anniversary of the founding of the American Heart Association. It was quite an interesting week. And what I want to then go through with you is 100 years of progress, talk with you a little bit about what I'll call the humbling heart and stroke statistics today, talk about, as Dr. Fuster has done, his research as the centerpiece for progress, key topics for the coming decade, and then I want to go through these key topics: the chronic disease burden, the global burden, health inequities, but yet with the hope that remarkable advances are still to come. And I'll try to outline, at least from my vantage point, what some of those might be. Circulation has been publishing a series of papers on celebrating 100 years of progress through the Heart Association, and take a look at them. There's really a lot of terrific papers written by a variety of people in the field who are working at the intersection of a lot of different aspects of science and clinical medicine. This is a great one from a group of the former AHA presidents that's summarizing that 100 years of progress. This week in Chicago, we actually celebrated the 100th anniversary at the site where the Articles of Incorporation of the Heart Association were signed by these 6 physicians in 1924 at the Drake Hotel. In 1921, it had become apparent that cardiovascular disease was emerging as one of the leading causes of death in the United States. And so these 6 physicians, visionaries in some ways, saw that there needed to be an organization to come together initially to support the exchange of educational information, but progressively over time, and particularly as we get into the post-World War II era, to really think about contributions to science, and that it was going to be science that was going to help us make progress. I was especially pleased to learn that Lewis Conner is one of the 6 founders of the American Heart Association. Lewis Conner was the 2nd chair of medicine at Cornell Medical College. His picture now for this year hangs outside my office that they retrieved from the archives to be able to think about the celebration and what's been accomplished, but maybe more importantly, all the things we still have to do. And on this slide, I want you to both take great pride because you've all contributed to the decline in age-adjusted death from heart disease and stroke over about the last 70 years or so. But I also put this up as the cautionary tale. And you can start to see that around 2015, there's a flattening of that incidence curve, and that you will start to see as we get into 2019, 2020, there's actually been a reversal in deaths, the decline from deaths in cardiovascular disease. Yes, we're far better off than we were 70 years ago. Yes, we're better off than we were 10 years ago, but we're losing ground. And all of us in the room have a collective responsibility from a societal perspective to try to help address that. This is one of the most important papers that comes out every year from the Heart Association, the Heart and Stroke Statistics, which is really a deep dive into all of the public health information around cardiovascular risk factors, prevalence of diseases, in particular coronary disease, heart failure, atrial fibrillation, hypertension. Take a look at this, because it starts to give you the basics for where we should begin to think about as a society of concentrating our resources. And I would submit to you that the most important gains are going to be in the prevention era, and the very most important gains are going to be in prevention in young people. The statistics are humbling. if you think about how many of us, how many of our fellow citizens are dying annually still from cardiovascular disease. Someone dies of cardiovascular disease every 30 seconds in this country. Somebody dies of a stroke about every 3 minutes. Think about that as we're all sitting here. How many people are dying from the disease that we're all interested in both caring for and studying? And in large part, the risk of cardiovascular disease continues to increase because the risk factors, as Dr. Fuster has shown us, continue to increase. The increasing burden of diabetes, the increasing burden of obesity, the increasing uncontrolled hypertension across the globe. These are the major problems that are going to be the ones that we have to address. We've made great progress in tobacco with huge efforts by a lot of people since the Surgeon General report in the 1960s. But we're losing some ground. In particular, we're losing some ground because of things like electronic cigarettes. And if you look at things like vaping amongst high school students, we've made progress in the last 5 to 7 years, but we've not eliminated it. And I'd submit to you that the two most important things we as a profession could do would be the elimination of all tobacco across the globe and the control of blood pressure. If we do those two things, we'll save lives, and we'll save a lot of lives. Now, I said that on an annual basis, the most important paper to take a look at every year is the heart and stroke statistics. The two most important papers I've read this year were published in the last couple of weeks. One is on forecasting the burden of cardiovascular disease and stroke through 2050. And the other I'll show you is the economic implications of this. This was the topic of much discussion at the AHA meetings this week, because this tells us that our work is far from over. In fact, for those of you who have read this paper, I hope you came away a little bit depressed. My first read of the paper, I was very depressed. I was one of the reviewers of the papers, and I sent in my review and I said, can you not put some hopeful news in here? What happens if GLP-1 agonists actually do work over time and we treat the obesity issues? What happens if we actually get the wherewithal to control blood pressure at the population level? So there's some of that in there, of the hopeful forecasting. But if you look at 2050, which is not that long from now, the burden of disease is going to be extreme. The burden of obesity, the burden of diabetes, the burden of hypertension, and that's going to cause about a 2% absolute increase in the prevalence of coronary artery disease. It's going to cause an increase in the prevalence of heart failure and an increase in the prevalence of atrial fibrillation. This is a big deal, and we all need to be thinking about it as we think about how we're going to address it collectively. And if you really want to get depressed, read this paper on forecasting the economic burden of cardiovascular disease and stroke. Now, this is modeling. This is what economists do. They look at information today, they look at past historical information, and they model looking forward. Doesn't mean that this is exactly what's going to happen. But if you look at it, the cost, both direct and indirect cost, of caring for people with cardiovascular disease and stroke is going to quadruple by 2050. That's not sustainable as a society. The economics of that can't be supported. But that's what's going to happen, and that's the burden that's going to be put on all of us as professionals, as taxpayers. This is a big deal. Take a look at this. Now, how have we made the progress of the last 100 years? Terrific sort of overview of the century by Dr. Brunwald, a century of progress. It's been science, it's been research that's gotten us to this point. Yes, it's been coupled with public health measures. The Surgeon General report is a great example of that. But it's been driven through research, through science. And Dr. Fuster's talked about some of this. The immune mechanism of atherosclerosis, trying to understand clonal hematopoiesis as a new risk factor for cardiovascular disease. So it's really science that's gotten there, and all of you who have contributed to that, you should celebrate this. But this is the worry. This is a terrific viewpoint from Rob Califf, the FDA commissioner, that he wrote a couple of years ago that's looking at the unsuspecting public in the coming tsunami of chronic diseases. The FDA actually has an advisor now on chronic diseases. Dr. Califf and others are trying to understand, how do you use the power of the regulatory arm of the U.S. government to drive change, to drive reform, so that we can think about, can we make a difference here? Because it's coming. And if you look at the statistics on obesity, you look at the statistics on diabetes, hypertension, it's coming. During the course of the pandemic, as a society, we lost 10 percentage point control of high blood pressure. Think about that. High blood pressure control as a population was over 50%. It dropped down to the low 40s. We need to do better. We also need to think about this from a global perspective, because so much of the health of the globe depends upon cardiovascular health. And here, as a cardiologist, we also start having to think differently. You can't have a conversation about health and cardiovascular health for the future without thinking about planetary health. We need to be thinking about climate. We need to be thinking about air quality. These are all critical issues that's going to affect the diseases that we care for, the patients that we see. And this is going to be particularly disproportionately affected in the emerging economy countries, where air quality is less than here. But let's not fool ourselves. Some of our cities have air quality, particularly with things from wildfires, for example, that are affecting cardiovascular disease, myocardial infarction incidents. You've got to be thinking about this. And who's going to bear the burden here? The burden is going to be borne by those most vulnerable amongst us. If you look at where the greatest growth in the burden of cardiovascular disease, it's in non-white populations, it's in rural populations, it's in migrants and immigrants coming to the United States. So we have to be constantly thinking about this, and what I would ask all of you as cardiologists and cardiovascular professionals, you have to get engaged in this. The policy pieces here, who we vote for, is critically important. You've got to be thinking about these sort of things if we're going to make a difference. Rural health in the United States is abysmal. And this year it's estimated that another few hundred hospitals are going to close in rural America. Fewer hospitals, less access to care, growing burden of cardiovascular disease and cardiovascular risk factors. But as always, we're going to step back and think about what we can do. And I would say that what we have to do is think about that spectrum of science. And there's so much fascinating stuff that's being done, from basic discovery through clinical investigation up through population health and policy. And for the young people in the audience, I'd say pick your lane. Are you a laboratory scientist, a clinical investigator? Are you interested in policy and big macro questions? There's a role for you. There's things to do. And there's exciting things to do. I talk a lot these days about medicine as a data science. And data science, I think, is going to lend some enormous insights into what we're doing. The ability to gain new insights from what I'll call very disparate data sets, large omics data sets combined with imaging data sets, combined with population health data sets. We're going to be able to get large insights into this because data is ubiquitous, it's everywhere, and because of the other key contribution in the last 10 to 15 years, and that's cloud computing. Artificial intelligence, machine learning, these are not new. You can go back to the radiology literature in the 50s and find papers on using artificial intelligence, using the computer to read images. But what's really changed is cloud computing and the ability to handle massive amounts of information in ways that we can't in some ways comprehend how the machine is doing that. At least I can't. And so we are going to see artificial intelligence and the tools of artificial intelligence, like machine learning, really change healthcare. It's going to change the delivery of care. It's going to change medical education. It's going to change how we think about doing research. Now that I've moved to my new position, people have asked me, what are some of the things you're going to concentrate on? This is probably one of the most important things I'm going to concentrate on for the years ahead. And it's something I've thought about for 30 plus years. And we've made, I would say, very incremental progress. And that is, how do we better integrate research into practice? It sounds so simple, and it's really hard. We saw some great insights from Dr. Fuster on acute coronary syndromes. Do you know that less than 5% of acute coronary syndromes in the United States are entered into clinical trials? Less than 5%. This is one of the most common diseases that are seen in U.S. hospitals. It's not much better in other parts of the globe, but less than 5%. We've got to do better, and we have the tools right now to do better, and I'm going to look to many of you to help. A group of us were involved with the Reagan-Udall Foundation this past year, which provides advice to the FDA on what they can do better. And the FDA is committed to this notion of how do we continuously generate information on common things that we're all interested in. I always like to come back to Dr. Stead, and some of my Duke friends in the audience will remember Dr. Stead. He was a real visionary. Dr. Stead was the longtime chair of medicine at Duke University, and I would say he had a lot of contributions, but two stand out to me. One of which is that Stead was the founder of the Duke Databank for Cardiovascular Disease back in the 60s, when he said we should use the computer to aggregate information and to provide that information to clinicians to take better care of patients at the bedside. He said this in the 1960s. The second thing he did was that he created the physician assistant profession. He had this notion of team-based care way before it was popular. But I also love the quote of Stead on his biography, which is, what this patient needs is a doctor. When something really complicated would get presented, Stead would often step back and say, you know what this patient needs? He needs a doctor. And I would say that artificial intelligence needs a doctor. We've got to make sure we don't take the humanism out of medicine, because at the end of the day, that's what medicine is. It's a human art built on scientific principles, and I don't want us to forget that. Finally, where do I see the other advances coming? The interface of engineering and medicine is really still untapped. The great advances, earlier this morning, Dr. Sharma talked about Dr. Grunsing. That was the intersection of engineering and medicine that revolutionized our field. There's so much more we can do with bioengineering, tissue engineering, cellular regeneration, large-scale imaging and reconstructing of body parts. I mean, there's the possibilities here that we're only beginning to scratch the surface. So let me end where I began, and I hope I've talked about great work, all of you. You should give yourselves a collective hand. But then if you stop doing that, start to think about what we have to do next. There's an enormous burden of cardiovascular disease coming, and all of us in the room have a collective responsibility to try to address this. The burden of chronic disease is just immense, but we have the tools. We have the tools of science, we have the levers of public policy, and we need all of you to play your role along the way, whether it's caring for patients, working at the laboratory, using large data sets, or trying to make change in the public arena. Thank you for having me, and I look forward to the rest of the day. Bye-bye.